name is Ronnie Decker. I'm a registered nurse, and this is Nursing Analysis. Today, we will be learning how to complete a thorough head-to-toe physical assessment. We will be reviewing the supplies and techniques needed to perform an assessment, and then we will be going step by step through an actual assessment. We must understand that during an exam, physical contact may have different meanings in different cultures. For example, some Arabic and Hispanic cultures, a male examiner may be prohibited from examining all or certain parts of a female client's body. To begin our assessment, we must first gather our supplies and equipment. We will need a pen light, stethoscope, blood pressure cuff, pulse oximetry meter, an otoscope, a tongue depressor, a scale for weight, and tape measure for height if your scale does not have one, calipers for skin fold measurements, and a Snelling eye chart. A pleasant smelling fragrance, cotton balls or swabs, a sharp object such as an open paper clip, and gloves. We need to arrange for adequate lighting, and we must ensure the location is quiet and comfortable, and that we provide privacy by using proper draping and only visualizing one section of the body at a time. We must remember to educate the patient about the various assessment techniques that will be used during the procedure. Our nails must be short, and hands and stethoscope should be warm before coming into contact with the patient. Always have necessary equipment available, and always use standard precautions when in contact with body fluids. Let's now discuss the four main methods used during an assessment in a specific order. This includes inspection, palpation, percussion, and auscultation on every body system except for the abdomen. For this area, we will inspect, then auscultate, then percuss, and then lastly palpate, in order to avoid altering bowel sounds. Inspection is our first technique, which utilizes our senses such as vision, olfaction, which is smell, and hearing to observe and detect any expected or unexpected findings. We will utilize a pen light to enhance our vision. We will check for size, shape, color, symmetry, and body position. We will utilize our sense of smell to detect any abnormal or malodorous scents. Our second technique, palpation, involves touch. We can determine size, location, consistency, texture, temperature, and tenderness to each system or body part. This includes both light palpation, which is usually at a 1/2 inch or less, and deep palpation, which is 1.5 to 2 inches and is usually used to assess abdominal organs. Always start with light palpation first and only progress to deep palpation when necessary. Our third step of techniques is percussion. This involves the tapping of body parts with fingers to evaluate size, location, tenderness, and presence or absence of fluid or air in body organs. The denser the tissue, the quieter the sound. Our fourth step and technique is auscultation. This is listening. Some sounds are loud enough to be heard unaided, but most sounds require a stethoscope. These include heart and lung sounds, or blood moving through vessels. We will evaluate the amplitude or intensity, which can either be soft or loud, the pitch or frequency, which again can be either soft or loud, and the quality and duration. It is important to note in regard to the stethoscope, the diaphragm is used for high-pitched sounds such as heart, bow, and lung sounds. The bell is used for low-pitched sounds such as unexpected sounds like bruits and murmurs. It is important to remember, never feel or listen through clothing, which can obscure or produce artifact sounds. Now we can begin our physical assessment. We will perform hand hygiene, and then we must knock on the patient's door and ask for permission to enter. Once we enter, we will introduce ourselves. Hello, my name is Ronnie Decker. I will be your nurse involved in your care today. We must ensure that privacy has been maintained. Then we will need to identify the patient, their name, date of birth, and if they have any allergies and what happens with the allergic reaction. Can you tell me your name, sir?
Alex Back.
And can you tell me your date of birth?
August 21st, 1993.
Can you tell me what day of the week it is?
It is Thursday.
And can you tell me who the president is?
Donald Trump.
And can you tell me what we will be doing today?
We will be doing a full body examination.
Thank you. We will verify the armband with the MAR or medical record. Identification should be confirmed by using two separate patient identifiers. Explain the procedure to the patient and confirm that the patient is okay with the procedure being performed. I need to perform a head-to-toe assessment on you. Is this okay?
Yes.
Next, perform hand hygiene again in front of the patient, and then don gloves. Always ask the patient if it is okay to touch them before performing any assessments. During this assessment, make sure the patient is in a safe position and all the patient's needs have been met. During this process, we are already able to check for alertness and orientation. We also ask the patient to tell us where they are, what month of the year it is, and what procedure we need to perform. So person, place, time, and situation were answered correctly. So, our patient is alert and oriented ×4. We also should know whether the speech is clear or slurred, if the skin color is consistent with ethnicity, if the attire is appropriate for the occasion, if grooming and hygiene is well maintained. Were they able to hear the questions asked? We are able to assess their presenting physical appearance, including the estimated age, sex, facial symmetry, stature, nutrition, posture, and body build, and if their mood and affect are congruent. We must also note any outward abnormalities, such as amputations, disfigurements, lesions, masses, sweating, cold clammy skin, or even cyanosis. Now, we must collect the patient's height and weight, skin fold circumference if indicated, temperature, heart rate, respiratory rate, blood pressure, oxygen saturations, and pain level. Alex, are you having any pain today?
No.
Usually pain is rated on a 0 to 10 scale, 0 being no pain and 10 being the most severe pain. We may also include body mass index, which, remember, less than 18.5 is considered underweight. 19 to 24 is ideal, and 25 to 30 is overweight, and greater than 30 is obese. Now we will begin with inspection of the head. This includes checking skin color and head size in comparisons to the body size. We need to inspect and palpate the head, scalp, and cranium, noting any abnormalities such as masses, indentations, and skin breakdown, or any infestations. Palpate for the strength of the pulse in the temporal artery bilaterally. Now we must check the face for proper expression, abnormal movements, spasms, and symmetry. We look and make sure the eyes and ears are at the same level. There should be no obvious signs of work of breathing, such as flared nostrils. Now we can check the facial nerve, cranial nerve 7. We will have the patient close the eyes tightly and then open them. Alex, can you close your eyes? Now open them. And can you smile for me? Now can you frown? And can you blow your cheeks outward, keeping your mouth closed? We can now assess cranial nerve 5, which is the trigeminal nerve and is responsible for mastication. Can you bite down for me? We are palpating, do it again please. We are palpating the masseter muscle, which should be a nice formed ball. We must also palpate the temporal muscle. We'll have the patient open their mouth against resistance. Can you open your mouth for me, Alex? Inspect the temporal mandibular joint as the client opens and closes his mouth. Can you open your mouth? We're checking for any grating or clicking sensations. Now we must palpate the sinuses. We will put pressure on the maxillary and frontal sinuses and tell the patient to let us know if any pressure is felt. Alex, did you feel any pressure or pain?
No.
Next, we can move to inspection of the eyes. We need to check the eyelids, the sclera, or the white of the eye. We must also note the iris and pupil and assess both conjunctiva. Healthy eyes should have no swelling, jaundice, or yellowish color, no muddy looking sclera or redness. The conjunctiva should be pink and moist. Can you look up for me? Thank you. Now we will assess the eye position in relation to the eye socket. How do they sit? We will check for any strabismus or crossing of the eyes, or any abnormal up and down movements in the eye. We can also check for anisocoria, which is pupil size in relation to each other. Is one pupil smaller than the other? Normal pupils are at 3 to 5 milliliters. Alex's are about a 4. We can now assess cranial nerves 3, which is oculomotor, 4, which is trochlear, and 6, which is abducens. We will check for any nystagmus, which is any involuntary shaking of the eye. To check cranial nerve 2, which is the optic nerve, we need to check the visual fields by confrontation. Have the patient cover one eye. Alex, can you cover one eye for me? And with your pen light, utilize peripheral movements and see if the patient can detect your movement. Did you see these movements?
Yes.
And then repeat with the other eye. Now we will conduct the 6 cardinal fields of gaze. We will use our pen light at a distance of 12 to 14 inches from the patient's nose. We will hold the pen light vertically and instruct the patient to keep their head still while following the pen light with their eyes as we move it in a direction of diagonal up right to diagonal down left. Then from midline, diagonal up left to diagonal down left. Again from midline, horizontal left and horizontal right as we look for any abnormal shaking of the eyes. Now we must test pupil reactivity to light. We need to dim the lights in the room and have the patient stare off at a distant object. This will help dilate the pupils. Using our pen light, we will enter each eye from the side. The pupil should constrict with the added light in both pupils. So this one constricted and the other one constricted as well. Let's see. Yes. Okay. We will now turn the lights back on and test the eyes for accommodation. With the patient staring at a distant object to dilate the pupils, we can use our pen light or a finger at a distance of 12 inches from the tip of the nose. Alex, just look straight at the pen and don't move your head. We converge directly toward the nose. The pupils should constrict or accommodate and the eyes should cross while focusing on the pen light or finger. Since our test was normal, we can state the patient's pupils are equal, round, and reactive to light and accommodation. This is where we get the acronym PERLA. With normal room lighting, we will now inspect the ears. We are checking externally for position, alignment, skin condition, and the auditory meatus, which is the opening into the ear. Next, move the pinna and push on the tragus to detect any tenderness. Alex, you felt any tenderness or pain?
No.
We can also check around the auricle for some tophi or urate crystals, which are white yellowish nodules caused by uric acid accumulation. This is seen with patients who have chronic gout. Alex, let's see. No, his auricle looks pretty clear. Next, we palpate the mastoid process found behind the ears. Using an otoscope, we will now visualize the auditory canal and include the tympanic membrane, which should be pearly gray, translucent in color, and shiny. We must remember to pull the pinna up and back in adults. We investigate the ear for the cone of light, which should be at 5 o'clock in the right ear and 7 o'clock in the left ear. We can now assess cranial nerve 8, which is vestibulocochlear or acoustic. To assess the client's hearing, begin with the voice test. We will occlude one ear and whisper 2 words on the other side and see if the patient is able to repeat these words. Alex, can you tell me what I said?
75.
Alex, can you tell me what I said?
57.
Perfect. We will now move to inspection of the nose. We are checking for symmetry and lesions and note whether the septum has any deviations. Ask the patient about any irritation, drainage, or stuffiness. Alex, have you had any drainage or stuffy nose lately? Any tenderness or pain?
No.
Okay. Now we can check for patency of the nares by asking the patient to occlude each nair one at a time. Alex, can you cover one of your nostrils and breathe in for me and out? Thank you. Now can you do the other one? We listen for airflow. This confirms patency. Using our pen light, we will now inspect the internal nares. Can you lift your head? Check the septum for any deviation, any redness or drainage, or polyps that could impede airflow. We can now assess cranial nerve 1, which is olfactory. We will ask the patient to close his eyes. Can you close your eyes, please, Alex?
Yes.
And we will ask them to identify a pleasant scent placed in front of their nose. Alex, can you tell me what you smell?
Pineapple.
Pineapple, correct. Now we can focus on the mouth and throat. If the patient is coughing or sneezing, a mask and shield may be required. We must first inspect the lips. Are they pink and moist? Are there any sores or chapping? Any dusky or cyanosis discolorations, which can be a sign of hypoxia? Using a pen light and tongue depressor, inspect the inner mouth, including the teeth, gums, tongue, floor of the mouth, buccal mucosa, the palate, and the uvula. Alex, can you please open your mouth? Let's see, check this one. Okay. Can you say ah? Very good. If the tonsils are present, grade them on a 4-point scale. 0 means normal. 1 would be slightly enlarged. 2 would be moderately enlarged. 3 would be severely enlarged. And 4 would be completely touching. Now we can assess cranial nerve 12, which is the hypoglossal nerve. Alex, can you stick out your tongue for me and move it side to side? The tongue should be pink and moist. We must remember a beefy red tongue can be a sign of pernicious anemia, and a dry, cracked tongue can be indicative of dehydration. We must also assess under the tongue, looking for any lumps or abnormalities. We check the teeth for caries or teeth that are loose or broken. We check for exudate or thrush, and we assess the soft and hard palate. We make sure the uvula is midline. We now can assess cranial nerve 9, which is the glossopharyngeal nerve. Alex, can you open your mouth and say ah?
Ah.
Stick your tongue out and say ah.
Ah.
You don't have there we go. We have now stimulated the gag reflex by gently stroking the uvula with the tongue blade. We can also assess cranial nerve 10, which is the vagal nerve, if our patient is able to communicate without hoarseness and has the ability to swallow. Alex, can you take a big, hard swallow for me? Thank you. We now must doff our gloves and perform hand hygiene and apply a new pair of gloves. We will now inspect the neck for symmetry, lumps, and any pulsations. Then ask the patient to extend the neck. Alex, can you extend your neck? So we can assess the trachea and make sure it is midline. And now we can assess cranial nerve 11, the spinal accessory nerve. We will ask the patient to move their head up and down and side to side. Alex, can you move your head up and down for me, please? And then side to side. Very good. We will then provide resistance bilaterally on Alex's shoulders and ask him to shrug his shoulders against resistance. Alex, can you shrug your shoulders, please? Thank you. We now must position our patient at a 30 to 45 degree angle. We will have the patient turn their head to the side so we can assess the jugular vein. Can you turn your head to the side, Alex? We are noting any distension. We can now palpate the trachea and make sure it is midline. To test range of motion in the neck, we'll have the patient move his head forward and back, and turn his head to each side and shrug his shoulders. Alex, can you move your head forward and back? Great. Alex, can you turn your head side to side and shrug your shoulders? Wonderful. We must now palpate all lymph nodes and again ask the patient to report any pain or tenderness. Alex, let me know if you feel any pain or tenderness, okay? We are looking for any hardened areas or inflammation. We start in front of the ears, pre-auricular. We then move to post-auricular. We check the occipital area. We check the parotid area, then jugulo-gastric, then submandibular, then submental, then superficial cervical, as we proceed to the deep cervical chain, and then to the posterior cervical, then down to supraclavicular. We can now palpate the carotid artery. We do this one side at a time, never bilaterally. We can locate this groove in the neck lateral to the trachea. His are +2 in normal. We now can auscultate the carotid artery using our stethoscope. We first must wipe down our stethoscope, and using the bell side, we are listening to hear or detect any disruption in blood flow or turbosity, which is known as a bruit. It will produce a swishing sound. We can now have the patient breathe in and out, and then hold his breath. Please note that in healthy patients, we should not hear any sounds with the bell. Alex, can you take a deep breath? And then blow it out, and then hold. Good. Great. We now must assess the upper extremities, noting any lesions, redness, swelling, and we will palpate the radial arteries bilaterally. His are 2+ and equal. We can also check capillary refill in the fingers. We will press down on the nail bed and watch how fast the blood returns to that area. This should be under 3 seconds. Longer than 3 seconds can indicate a problem with blood flow. We can assess skin turgor by pinching the skin and seeing if the skin returns to its original form or whether it tints, which could indicate dehydration. Remember, per NCLEX, only the sternum and forehead are accurate for this determination. We now assess the fingers and hand for range of motion. We can assess the joint areas for abnormalities such as Heberden's nodes or Bouchard's nodes, found in conditions such as osteoarthritis. Ask the patient about any possible painful areas in the extremities. We now must palpate the brachial artery found in the bends of the arms. His are 2+. Now we must assess muscle strength by having the patient squeeze your hands and then have them push out with your hands around their wrists for resistance. Alex, push out. Ooh, his are 5+, which is normal strength. Now we will support the arm above and below the elbow joint. As we rotate, we are noting for any grating or crepitus during movement. Now we will assess the patient for any focal deficits, such as drifting in the upper extremities. We will have the patient hold their arms out extended with the eyes closed and monitor for any drifting, which can be an indication of a previous stroke. Alex, can you close your eyes for me and extend both arms? Okay, no drifting noted. If it were to be drifting, one of these arms would pop up like this, or this one would pop up like that. Okay. Now we are moving to the chest. Face the client to examine the anterior chest. If the client is female, loosen the gown in the front, but leave it on her shoulders. Then inspect the client's respirations and skin characteristic. Assess the anterior, posterior, to transverse, which should be 1 to 2. This means the distance from front to back should be half the measurement of straight across the chest. We need to also inspect for abnormalities like lesions, wounds, rashes, or deformities. We can also observe the patient's breathing effort. Are there any retractions or accessory muscles in use? Is there any barreling noted? Most COPD patients have this shape. We will now listen to the heart sounds in 5 locations. Each location is specific for a specific valve, except for Erb's point. This is more of a point of reference and the best spot to detect heart murmurs with the bell of your stethoscope. We can remember this mnemonic: all patients take medication. The first letter of each word corresponds to the valve. So our A would be utilized to auscultate our aortic valve. This can be found at the second intercostal space right of the sternum. The P for the pulmonic, which can be found at the second intercostal space to the left of the sternum. It is important to note the A as in aortic and the P as in pulmonic are ventricular semilunar valves. They represent S2, which is the dub sound in the heartbeat. Erb's point, as previously mentioned, can be found at the third intercostal space to the left of the sternum. The T, as in take, is our tricuspid valve found at the fourth intercostal space to the left of the sternum. And our M, as in medication, is our mitral or bicuspid valve, which is found at the apex of the heart or point of maximal impulse, located at the fifth intercostal space to the left of the sternum, mid-clavicular. We must note the tricuspid and mitral valves. Our atrioventricular valves, or S1, and produce the lub sound of the heartbeat. We can assess the apical pulse at the fifth intercostal space, also known as PMI, or point of maximal impulse, for 1 full minute. We can now switch to the bell and repeat auscultating all 5 spots to assess for murmurs, which are swishing or blowing sounds. We will start second intercostal to the right, the aortic, second intercostal to the left, the pulmonic, third intercostal, Erb's point, fourth intercostal, tricuspid valve, fifth intercostal, mitral or bicuspid valve, and also PMI, a point of maximal impulse. We can now move to the lungs. We are listening for abnormal sounds, such as crackles, wheezes, tighter. We use our diaphragm and start at the apex of the lungs as we tell the patient to breathe in and out. Alex, can you take a deep breath for me? And now out. We auscultate the right and left trapezius areas. We move to the second intercostal space to evaluate the right upper lobe and left upper lobe. Alex, can you take a deep breath for me? And out. Very good. And again. And out. And again. And out. We now move to the fourth intercostal space to assess the right middle lobe and left upper lobe. Alex, can you take a deep breath for me? And out. And again. And out. Remember, there are only 2 lobes on the left side, and there are 3 on the right. We now go mid-axillary to the 6th intercostal space. Well, let's check these areas first. Deep breath. And out. And again. And out. And again. And out. Okay, can you turn to the side a little bit for me? Okay, can you breathe in. And out. This is the mid-axillary. And then the other side. Hold on, let me do that again. Breathe in. And out. Great. Now we will inspect the lateral and posterior chest, noting the configuration of the thoracic cage, skin characteristics, and symmetry of shoulders and muscles. We will palpate to confirm symmetrical chest expansion by placing both hands under the scapula and observe as the patient breathes. Alex, can you take a deep breath and then blow it out? We're watching for how close the fingers come to touching. Next, we will palpate to detect tactile fermentus. We will have the patient say 99 while the palm of the hand laid on the back and observe for any vibrations. Alex, can you say 99?
99.
And again?
99.
Okay. Next, we will palpate down the spine to assess the spinous process. Then, percuss the costo-vertebral angle to detect any tenderness by placing the palm flat on the lower side of the back with the thumb up and tapping with the other hand. We now listen posteriorly using the diaphragm of the stethoscope. We auscultate the left and right trapezius areas. Alex, can you take a deep breath? And out. And again. And out. Watch out for the scapula. No sound is produced in this area. Now we move in between the shoulder blades and spine to assess the left and right upper lobes. Out. And again. And out. We move our way down, listening to the right and left lower lobes. One more time. Thank you, Alex. We now move to the abdomen, and this is where we switch the order of assessment to inspection, auscultation, percussion, then palpation. We will have the patient lay on their back and we will inspect the abdomen's contour. Is it flat, rounded, scaphoid, or protuberant? Symmetry, skin characteristics. We will assess the umbilicus and for any pulsations. If we observe any aortic pulsations, this may be a normal finding. We will also note any hernias or masses. We will ask the patient when their last bowel movement was, or if they are experiencing any abdominal issues. What the color, consistency, or the presence of any abnormal smells of the last bowel movement. We will ask them about voiding, including any urgency, frequency, or any pain or discharge, or any problem starting or stopping a stream during voiding. For female patients, we will ask when was their last menstrual period. Now it is time to auscultate the bowel sounds. We will clean and warm our stethoscope, change our gloves, and wash our hands. We will start in the right lower quadrant. We will then ascend clockwise to the right upper quadrant. Then proceed to the left upper quadrant. And finally, the left lower quadrant. We will listen for sounds in each quadrant. 5 to 30 sounds per minute is normal. We must listen for 5 full minutes in each quadrant. If no bowel sounds are auscultated, the sounds can range from hypoactive, normal, and hyperactive. We will now auscultate for vesicular sounds in the abdominal area using the bell of the stethoscope. We will be listening to the aortic, renal, and iliac arteries. The aortic is under the xiphoid process. 2 inches diagonal, right and left, we listen for the right and left renal arteries. Then we listen to the iliac, which is an inch below the umbilicus to the left and right. You can also listen to the femoral artery in the groin, but we are skipping this step today. We must now do light palpation followed by deep palpation, starting in the right lower quadrant, feeling for any lumps, masses, or rigidity. We will ask the patient to report any pain or tenderness. Okay, just let me know, Alex, if any of this hurts. Everything okay so far?
Yes.
No pain?
No pain.
No tenderness?
No.
Okay. Great. We will now proceed to deep palpation, starting in the right lower quadrant again. How does that feel, Alex? You okay?
Yes.
Any pain? Any tenderness?
No pain, no tenderness.
It is important to note most people need 2 hands to get this accurate depth. We now move to the lower extremities. We'll inspect the color of the legs and feet, check for hair growth, which can detect vascular issues when there is no growth and the legs appear shiny. This would be indicative of peripheral artery disease. Alex's legs look good. We observe for any abnormalities such as edema or redness and ask the patient if they are experiencing any pain. Alex, are any pain or tenderness anywhere where I'm touching?
No.
Okay. Check for redness to the joints and check the patient with neuropathy such as diabetics, because they may not be aware of skin openings, so you have to check underneath the bottom of the feet. We must check the nail beds for fungus. And check the pulses. The popliteal is behind the bend of the knees. We can check the temperature and push on the tibia and assess for any edema. We need to make sure there's no indentations. We can check the posterior tibial pulses, which are behind the ankles, then the dorsalis pedis, which is on top of the foot. We check the cap refill on the toes. We will assess lower extremity strength. Have the patient push their feet against your hands. Alex, push your feet out, out, all right? Then raise the legs against resistance, which I can. Okay, very good. We now assess Babinski's reflex, which will stimulate the toes to curl. Good job. Good job. We have a negative normal response. Please note that in infants, the toes will flare. If the toes flare in adults, we are suspecting neurological concerns. We now must doff our gloves and perform hand hygiene.
It is now time for the Rhyme Time Review. We will utilize this rhyme to give us a hint, so we can remember what is included in a proper physical assessment. Remember the techniques the video show when evaluating your patient from head to toe. Gather your supplies you must first seek in order to perform your nursing techniques. Take a step back and remember the different sculptures. We must keep our mind open when working with different cultures. Now, what is included in our supplies? We will start with the pin that lights up the eyes. From the stethoscope to the blood pressure cuff, we still know this is not enough. Pulse oximeter, otoscope, and depressor. Remember what you have learned from your professor. We need a scale for both height and weight. If growth and development is what we must rate, we must remember all our tools included in our cart. And please do not forget your Snelling eye chart. Now check the light. Make sure it is right. We need the poise to control the noise. It is essential to keep this confidential. As for the patient and their fate, we will address our intentions and educate. Keep our nails at a short, filed form and make sure both of our hands are properly warmed. We introduce ourselves and describe our plan as we proceed to the sink to wash our hands. Identifying the patient in a specific way, have them repeat their name and listen to what they say. Now check the wrist above the hand, the one that includes the identification band. Make sure you tell them what you are going to do. Hello, I need to perform a physical assessment on you. Now we will check cognitive relations, confirming alertness and orientation. Now, how was this speech? Were you able to teach? Tell them the ways you need to check as you cover every area when you inspect. The heart and lungs you will rate as you listen to both and auscultate. Remember the GI border. The techniques here are done in a specific order. We start on the lower right side and use the clock's motion as our guide. Percussion and palpation must wait until we inspect and auscultate. On the top of the head, we start spreading the hair part by part. We feel for a lump and look for a bump. Do we notice any relations? How about any indentations? Now to the space that expresses the face. Is everything in place? We must give the nose a stare. Do the nostrils flare. How does each side compare? We must now observe the 7th cranial nerve. With the eyes closed tight, in adequate light, can they open them right? In single file, we now confirm their smile. Now close the mouth and do not speak as you observe the blowing out of each of the cheeks. Now we move to cranial nerve 5. This is what keeps mastication alive. We use persistence to check the temporal muscle's resistance. As we palpate the temporal point, was there any clicking or grating from this joint? We now measure pressure as plus or minus as we palpate the maxillary and frontal sinus. We can now move to the eye and test its sight, checking the sides of left and right. We remain polite as we look at the white. Compare the pupil relation. Is there constriction or dilation? Test the sight at each station, including accommodation. Give the patient lots of praise as they follow your directions with the 6 cardinal fields of gaze. There are 3 cranial nerves the eye picks, numbered 3, 4, and 6. We check for reaction with light's touch, checking for any signs of nystagmus. Give your focus and do not rush as we also watch out for any strabismus. The eyes are done and able to tear, so now we can move to the ear. Collect your data, present or historical, as we check the outer portion of each of the auricles. Upon inspection, what could we see? White-yellow nodules known as tophi. We now must look inside. Using our scope as a guide, we make sure everything is all right by locating the cone of light. In the ears, we must also rate the function of cranial nerve 8. Now we must occlude each side and go to the opposite to hide. Which ear is crisper? Can both detect our whisper? We now must check the nose. Is the septum forming a straight road? Have them occlude each nostril before you leave, so you can hear each one as they breathe. Do not leave yet, you are not done. Olfactory in the nose, cranial nerve 1. We now move south, down to the mouth. Is everything normal? We must vote as we check the tongue, teeth, and throat. The uvula rising confirms cranial nerve 9 as we leave nothing behind. As we talk to the patient, we must wait to determine if they are able to communicate. So now what's next? We must remember the gag reflex. After they swallow, the throat becomes hollow. Once they swallow again, we can evaluate cranial nerve 10. Downward we move and inspect, checking the trachea and neck. We will check head movement at every curve so we can assess the 11th cranial nerve. Remember to watch every notion. As we check for proper range of motion, make sure you are able to properly see as you place the patient at 30 degrees. There is something else we must mention. Checking for jugular vein distension. We must remember to trace with our fingers down every road so we were able to palpate each and every lymph node. To the patient we will render to tell us if they feel anything tender, and do not pass any type of detectable mass. We now test circulation for loss as we palpate bilateral pulse. Now check the nail bed for the return of the color red. How well does the blood spill? Measured by cap refill. Remember to check all points and abnormalities of any joints. This is what we are rating. Any crepitus or grating. Now to the chest. Both of our eyes will rest to determine what's best. Now please rehearse this next verse that measures anterior, posterior, and transverse. Is it too broad or is it too narrow? Does it resemble a barrel? Now we must start the auscultation of the heart, part by part. Now don't get hostile. Put stethoscope right, second intercostal. From me to you, this is the first sound of S2. Make sure to go under clothing to avoid the rub. S2 is the sound that makes the dub. To left from center of chest, we are not through. Put your stethoscope in intercostal 2. The stethoscope is supersonic as it can auscultate the pulmonic. We all know this is true as we listen to the other part of S2. Now our intercostal space is 3. So now, where can this place be? Flip to the bell, which is firmer, so you can detect any murmurs. Down we move to the 4th space. As S1 valves, we now trace. We are now valve shopping. With each intercostal, we are dropping. From 4th to 5th, we now shift. Try it before you buy it. I bet this sounds like fun. As we evaluate S1. And remember what I said about the rub. You are now evaluating the sound of the lub. The last place you will trace is the 5th intercostal space. For apical pulse, we rely on the location of PMI. Nothing should be lost at the point of maximal impulse. Do not forget the sounds of the lungs and what all 5 lobes have sung. Now down to the end in the abdomen. We start with right lower. To detect faster or slower, we must listen before touching around, so we do not disturb the bowel sounds. We now must check the leg to ensure the blood is fed. Nothing is lost if we can palpate a pulse. We are also hoping on the bottom of the foot nothing is open. The blood will not be still if we can confirm proper cap refill. To the doctor we are telling if we notice any swelling. We finish this track if the skin is intact. Health will remain and the patient will not complain. We have completed our mission as we were wishing. To below from above, now take off your gloves. Proudly we now stand, and again we wash our hands. Thanks for the time, my friend. We are now at the end. I hope for you this was fast, and on your test, you will pass.
Thanks to the Davis family, both Ryan and Shayna, for helping with the editing of the verbiage for this video. And thank you to Medical Prep Institute of Tampa for their long support with development of these videos. I appreciate it. And thanks to everyone who subscribes and watches.
Does it satisfy you to help others? Let us cultivate that feeling. Want to learn from a distance? We can reach you. Want to be excellent, providing compassionate care? We can bring the best out of you. Work with your heart as you solve problems. We can teach you how to critically